Hello and welcome to tonight's webinar on paediatric cardiology. I doubt our speaker, Dr. Nitha Naqvi, needs much introduction since she's a tour de force and is probably known to you all. But just to say that Dr. Naqvi is an indispensable advisor and trustee to our charity. She's a consultant paediatric cardiologist at the Royal Brompton Hospital in London and recently published a scientific paper on Marfan syndrome, its diagnosis and management in children. Dr. Naqvi is also a sensation on social media, consistently setting Instagram ablaze with her lively posts where she dispenses really useful heart-themed tidbits. And she sometimes shares the platform with her daughter, Sophia, who's a medical student and who volunteers for the Marfan Trust. So we're terribly lucky to have two generations of one wonderful family helping us. Welcome, Dr. Naqvi.
Okay, thank you. That was a lovely introduction. And just to say, yes, I'm working at the Royal Brompton Hospital, which is now part of a wider institution, part of Evelina and GSTT. So I'm going to start sharing the slides now, am I?
Yes, please.
Right, so now I've lost that icon.
Share. You have a strip
Oh
of...
yeah, no, I haven't lost it, sorry. Right.
And you have your Marfan mascot lurking in the background, huge Marfan mascot giraffe.
Now then. I hope this is the right one.
Yeah, yes.
Only it's not playing, is it? Okay, don't worry, let's hope Can you see something playing there?
I can see the pulse of life.
Can you see the heart beating?
Yes, I can.
Okay, right, okay. So I'm just going to talk a little bit about the heart, and I think you guys will probably know lots about it already, but it's the most fantastic organ that we have. As doctors, we're always arguing as which is the most important organ. Some people think it's the eye, some people think it's the liver or the kidney, but obviously I'm going to say it's the heart. So I'm a paediatric cardiologist. I've just added a bit of a disclaimer there, which we always have to do when we give talks, just to say that any advice we give is general, and even if we're speaking to somebody about their child, we would always say that always it's important to take your child to see a clinician who has got the time to examine your child and look at all the clinical notes and get all the information. So I'm, as I said, a paediatric cardiologist. I actually trained as a paediatrician first, which makes me slightly different to some of the other children's heart doctors, because I've spent a long time training in all different parts of paediatrics as well. This is my website, which is mychildheartdoctor.com. And I'm just flagging it because I've put various things on this website which are useful for parents before appointments, and also to explain things to their child, and also to understand a bit about the heart themselves. On it, I have a video of myself which is animated with this lion here. This is one of the patients at my hospital and his mum, who kindly volunteered to be in this video that was made by the Brompton Fountain, which is a charity that we have. And it's a video just showing me, before I lost quite a bit of weight, as you can see, doing an echo on a child. And it's often worthwhile if you can find different videos and things to show children what it's like when they're coming to hospital, especially the younger ones, because sometimes it's a terrible shock, and sometimes they think that they're going to be having an immunization and everything goes badly right from the start, even though there's no need for that. I've worked at lots of different hospitals. I don't know if you guys recognize any of them. I've worked at Guy's Hospital, St Thomas's Hospital, Birmingham Children's Hospital, Great Ormond Street, Northwick Park, UCH, the Marsden, Worthing. And my claim to fame, which Victoria didn't say, is that I'm Asian Woman of the Year. That's my favourite award. And like I said, I worked at the Royal Brompton Hospital, where we look after people with heart conditions from fetus to old age. And my area of interest, as well as paediatric cardiology with children with all types of heart problems, is Marfan syndrome and all different aortic problems. So I'm going to start with some questions for you. So what does the heart look like? I think you've probably all got an idea of what it looks like. For children, they often think it's going to look like this. And does any of you know why we think the heart looks like this? Why we're all told that, where this comes from? It's a bit tricky, isn't it? Probably didn't think I was going to ask you questions. Even Victoria's not sure. So this is the romantic love heart, isn't it? We've just had Valentine's Day, haven't we? But actually, the heart looks like this. This was kindly given to me by Andrew Cook from Heartworks. So it looks like totally different to the love heart. And children, when they're coming for a heart scan, often think that I'm going to see a love heart. The love heart shape actually comes from the silphium plant, which is so beautiful, isn't it? We've got to get one of these, all of us, for our gardens, because it just looks absolutely gorgeous. But our real heart doesn't look anything like this. So our real heart looks like this. My dad had taught me this, the Naqvi's rule of 4, that it's really easy to actually understand about the heart. There's 4 chambers, there's 4 heart valves, there's 4 big vessels, and I hope you can see the video at the bottom. But we have our blue blood that comes in our veins from our head and our feet to the upper chamber, the right atrium. Then it goes through this valve to the lower chamber, the right ventricle. Then it goes through this tube, the pulmonary artery, to the lungs, which give it oxygen. And then the red blood comes back from the pulmonary veins to the upper chamber, the left atrium, through this valve here, the mitral valve, goes into the left lower pumping chamber, and then goes through the aorta around the body. So the areas of interest for us when we're looking at people with Marfan syndrome in particular, we're looking at the aorta, this tube here, and we're looking at this valve here, the mitral valve, which is the one I've got here, which is controlling the blood going from the red blood, the oxygenated blood going from the upper chamber to the lower chamber. I've got this video actually on my website. So the ventricles in the heart, they're actually shaped like fruit. So the right ventricle shaped like a banana, and the left ventricle shaped more like a pear. This again was given to me by Andrew Cook, but this is very much how the heart looks inside. And on one side of the screen, I've got the echocardiogram, and then I've got an image of how the heart looks. So we can see that the heart valves are opening and closing, and they're attached to the heart, to muscles in the heart, and they're attached by what looks like lots of very thin strings. They're the cords. So this is the mitral valve here between the upper chamber and the lower chamber where the red blood is going. And we can see that it's closing very nicely. And also, can you see that its shape is like this? So it's closing like that. I don't know if you can see my hands there. It's closing like that. So I just wanted you really to look at the shape of this valve, that it's coming downwards. This is one of the leaflets, and the other leaflet, they're both coming down and closing down like that. And then this is looking at the heart valves from the top. It looks a bit like, to me, a bit like one of those man-eating plants. So this is the mitral valve here, the one in the left side of the heart, which is, we can see the strings a bit, but we can see how when it closes, it's closing fully, isn't it? There's no gap. And we can see that the valve tissue we see at the side is quite flat there. And this is the left ventricle, which is the one that I said was shaped more like the pear. And then this one, can you see how it's shaped a bit like a banana? Can I convince you on that? It's a little bit like a banana. That's the other shape, the right ventricle, which has got the blue blood. So when we, when we are talking about aortopathy, that's the medical word we have for conditions where there's a problem with the aorta. So that's all aortopathy means. Pathy is something we have in many medical words, which means there's a problem with it. And so aortopathy means there's an issue with the aorta. So this one is the normal heart, the picture that I showed you before. And can you see that the tube, the aorta tube, it's a bit hidden because it's behind the blue tube, which is how it is in real anatomy. But can you see it's not very enlarged, whereas this one, it's bulging out a bit here. And here it's bigger than here. Do you see that? How this is bigger here than in this one. I probably should have done them the same size, shouldn't I? So you could see them side by side. But this one, the aorta is the same size as we go round, whereas this one, it's quite bulgy out here. And even here, it's dilated, it's bigger than normal. And that's what we mean by aortopathy in children. In adulthood, other parts of the aorta can also enlarge, but in children, the first part of the aorta to enlarge is always this bit here, just above the valve there. That's the aortic valve there, which looks a bit like a Mercedes-Benz sign. There's lots of causes of aortopathy, but the commonest cause is Marfan syndrome. But there are various other causes that can lead to problems with the aortic valve, with the aorta enlarging. So I've got a question here, which is a question that I get asked a lot and causes lots of anxiety, which is where somebody, a couple having a baby, they have somebody in the family with Marfan syndrome or another aortopathy, either themselves or another relative, and the baby's just been born, and how worried should they be about their baby? So I put very, not at all, and a little bit. I think probably I'll make Victoria guess because it's a bit hard for other people. You're gonna have a guess, A, B, or C?
Oh, hold on. A.
Okay, so we as doctors and medical students, we get made to do so many exams, and we're always taught if you don't know the answers, always B. It's always B. So the answer is not at all, because if you have Marfan in the family, even if your baby has Marfan, there's not going to be a problem in the newborn period. So there's no need to worry at all. Everybody should just enjoy their baby in the normal way. And if there's somebody in the family with Marfan, we normally say we'd like to see that baby in the first 6 months of life. So you don't have to be worried when the baby's first born. And it's important, we want everybody to have as normal a life as possible and enjoy things as much as possible. So the things that we're looking at all the time when we see people in clinic with any type of aortopathy, particularly Marfan, we're doing echoes. And you're probably used to seeing the black and white pictures if you've ever had an echo scan or seen one on Instagram or on television. You see the black and white ultrasound, similarly to the black and white ultrasound we have when we're looking at the baby in the womb. And often it's difficult to see what the people doing the scanning are looking at. But what we're looking at is, in this picture here, the heart's on the side. And this is the left pumping chamber. And then this is the aorta here. So we're looking at that and we're measuring, particularly in aortopathy, we're measuring the size of the aorta. So this one's quite normal. And this one is much bigger. And that's what we're doing. We're just measuring different parts of the aorta and comparing it to normal. And already I can see that this one is a lot bigger than that one. Even the shape of it's different, isn't it? That this one is hardly bulging and that one is bulging a lot more. It looks a bit more like an onion tuber. In adults, what we do is we have normal ranges of what's a normal size. But in children, we can't do that because what's normal for a 2-year-old is not normal for a 5-year-old, not normal for a 10-year-old. Oh, sorry. I seem to be moving a bit there. So the way we work it out is on things called Z scores. And there's a way we do it scientifically, but the only point I would say that it's useful for families to know is a Z less than 2 is normal. So if there's any measurement where the Z is more than +2, then it means it's bigger than normal. The other thing we look at in Marfan syndrome, I've talked a lot about the mitral valve, which is the valve between the upper and lower chambers on the left with the red blood. So we look at it on the echo. So can you see the 4 chambers here on this echo? That's what we were looking at. So this is the valve here. That's how it would normally appear. Do you remember I said how it's going down? And this is how it normally is. But sometimes in Marfan syndrome, we have what we call mitral valve prolapse. So what we mean by that is the leaflets are going up. Can you see how they're much more up there than in this one? In this one, they're going down, whereas in this one, can you see my cursor? Do you see that?
No, I can't.
Oh, right. So probably nobody can. So if you look at the picture on the left, the most left one says a normal heart. And then the next one, that's the color one, says mitral valve prolapse underneath it. And the valve underneath the 3 white arrows is really bulging up. Can you see the leaflets are moving? Can you see how it's more like a letter M?
Yep.
So that's what we mean by mitral valve prolapse. And the main thing we're talking about is the bit where the valves join together is higher than normal. So the leaflets themselves are more bulgy up and they're also closing higher than normal. And can you see, if we look at, there's a picture D, which is the normal one, the normal echo. And then at the top right, there is a picture where the valve is the one that's, for me, it's like near the picture of Victoria on my screen, on the right side of the screen.
I can't see your cursor when it's tiny, little dot.
Oh, I see. But can you see? I'll move it as fast as possible so you can see it.
Yeah.
So that valve is more like an M. It's more up. And then the picture I've got at the bottom is the normal valve with the strings. And you can see it's kind of quite flat. But in Marfan, sometimes, instead of it being flat, it's all sticking up and it's closing higher up. Now I'm just going to talk about the different doctors who look after children. So I don't know if any of you have heard of a PEC. So a PEC is a pediatrician with expertise in cardiology. So they are a pediatric doctor, a children's doctor who will usually have spent a year, sometimes 2 years training in cardiology and will be looking after children with various heart conditions, but is not a fully trained cardiologist. So a fully trained cardiologist like myself will have done 5 full years at least of training in cardiology and will be working with all complex type of heart problems all the time, and usually will be working in a center where surgery takes place as well. And often we work together as a team, but that's the difference, because sometimes people get a little bit confused and they think they've seen a cardiologist when they've seen a PEC, and then once we've become pediatric cardiologists, we also have our different specialist areas. So mine is aortopathy and Marfan syndrome. Before that, I was very interested in echocardiography, and then some people are very much expert in being in the catheter lab, some of them in palpitation. So we all have different areas. Coming to Marfan syndrome, we know it's a genetic problem, and it's affects the connective tissue, so not just the heart, and it's 7 to 17 per 100,000, and the fibrillin 1 gene is the one that's mutated, which is on chromosome 15, and I've written there 15q21, and Q just means it's the long arm of the gene, and P is the little arm of the gene. We call it autosomal dominant, which just means that if you have somebody with Marfan syndrome and they have a child, there's a 50% chance the child could have it. So it's a little bit like tossing a coin there. We do now have ways that if you know you have Marfan syndrome, that using techniques a little bit of a variation on IVF, there's a way to ensure that your child doesn't have Marfan syndrome if that's something that you would want. And then also 25% of the cases are sporadic. And by that, we mean that the child is the first person in the family to have Marfan syndrome. Sometimes it's actually running in the family and people don't realize, so 3 out of 4 cases, there's somebody else in the family with it, and 1 out of 4 is just the first person and they're unlucky. And we tend to find that the ones who get the most difficulty in childhood and will need the most help are the ones who are the first person in the family to have it. So the child is the first person in the family to have it, and they're a boy. It's unfortunate, but that's something that we tend to notice. These are different famous people through history who people feel may have had Marfan syndrome. You might recognize some of them. This one here, I've put a bit of a difficult picture there. That's actually Tutankhamun. But if I put the gold thing, everybody guesses it straight away. This is meant to be Mary, Queen of Scots, who was famous for having very beautiful long fingers. And then the other people, I think you can work out who they are. So with Marfan syndrome, we know that it's the whole body that's affected, not just the heart. And sometimes people come to see me because it's been detected after an eye test. Sometimes the issue is the shape of the chest. Somebody's noticed that the shape of the chest is abnormal. Sometimes it's because somebody's noticed the person is very tall. Sometimes they've had a problem with their lungs, like a pneumothorax. So there's various ways that people come and present. And then different tests that we do, we look at the arm span. Normally the arm span, which we measure with the person's arms out, is always less than the height. But if it's equal to the height or more than the height, that's an indication. It doesn't mean that you have Marfan syndrome by any means, but these are different things that we look at. The other thing we look at is this thing we call the thumb sign, where when the person does that with their hand, if you do it yourself, you'll find your thumb isn't sticking out. But with Marfan syndrome, because the fingers and the thumb are very long, often the thumb's sticking out. And also, if you do this, they can, which is what in the picture B, which we call the wrist sign, the finger and the thumb can overlap each other. And then often some people are very, very flexible and can do all kinds of special things, and their tissue is very, very stretchy, but not always. We have various guidelines on how we manage aortopathy in children, some by the American Heart Association and some by the European Society of Cardiology, and they're not exactly the same. People have different ways of working, but at least we have guidelines to follow. Something that people tend to worry such a lot about is aortic dissection when there's a tear in the aorta. And what I want to say is that in all my years of working, which is now more than 25 years, I have never seen a child with Marfan syndrome have an aortic dissection. And I think that's like really important thing to say to people, because people, if they have it in their family, they worry so much about their children. Obviously, you know, you love your children more than you can ever imagine, but actually it's like extremely uncommon. It can occur in children in other aortic conditions, and it's very, very rare. And the things we look out for are chest pain, gut symptoms, feeling breathless, fainting, neurological problems like looking like you've had a stroke, or pins and needles. But children get all these problems much more commonly, which have nothing to do with having an aortic dissection, even when they have Marfan syndrome. So it's very, very rare, but that's the thing we look out for. I've seen in all this time 4 cases of aortic dissection. They were not actually in Marfan syndrome, they were in other similar conditions, but not in Marfan syndrome. And it's usually when it's an undiagnosed condition. Nowadays, if we're looking after somebody with Marfan syndrome and they're in the clinic and they're under follow-up, the whole point we're following them up is to make sure that doesn't happen. So it's something that people are very worried about, but like I said, it's extremely rare. Things that the parent and the older child need to know is that if you have severe chest pain, then the most important investigation is a CT scan. And I'm saying that to you because Marfan syndrome is not that common. And unfortunately, you may find that if you have a child with Marfan syndrome, you know more than the doctors that you meet in an A&E department. So I'm advising you what to ask for is a CT scan. This is if a child has very severe chest pain, and it really is very severe. They often feel like they've been stabbed or somebody's thrown a brick at their back. They look round to see who stabbed them. It's not just a mild feeling. But the most important is a CT scan, not an echo. Often people will be told, oh, you need an echo and then you need to go to another hospital for that. No, because we want children to be treated like adults. So in adults, we have like a target that if you have an aortic dissection, when you come to A&E, you have a CT scan within 1 hour. Most places are within 40 minutes. But if it's a child, you'll find they're not getting one for days. But we want children to be treated the same as adults because that's the best test and it's very quick. So an aortic dissection is a tear in the aorta. So this one, I don't know if you can see my mouse, but the picture on the left, it's in the beginning part of the aorta. Then in the second picture, it's in the lower part of the aorta. And if we cut the blood vessel and look at it under a microscope, we see that the blood vessel the wall is tearing. I'm trying to move my mouse as quickly as possible so you can see it's tearing into the wall. And that's what happens. Usually in a younger person, it would be more commonly this one. And by younger, actually, I'm not even meaning children. I'm sort of meaning people older than that. And here's the aorta in this picture on the left. I hope you can see my mouse, and I hope you can see. So there's been a tear in that tube. This is the tube taking the red blood out of the heart, and you can see there's been a tear, and the tear is actually here where this arrow is, and then this whole area here, which looks as if it's part of the aorta, is actually a false sac filling with blood. It's not connected to the normal part of the aorta. So any blood that goes in there is not going around the circulation normally, and that's a huge problem. And again, here in this picture, it's as if you're cutting it across here and you can see the tear. And this is a CT scan, and there is the tear, that line there. So if I show you this one, the picture on the left is a normal CT scan of a normal person. And the picture here is a CT scan of somebody who's had an aortic dissection. So the aorta is this circle here. This circle here, it looks a bit like a 10p coin. This one here. And in the person who's got a problem, the aorta is looking bigger, and also it's got a big line in the middle of it. So all of us, I think, can see that big line here. So this is why I'm saying about the CT scan is the best one, because nobody needs to be an expert to see it. And the X-ray, the radiology doctors in any hospital are used to looking at that. And that's much easier than an echocardiogram, which is really complex to look at. And even when there is a dissection, it's not always that easy to see. And then this is another CT scan looking at the aorta at the side, which looks more like a banana. And again, you can see the normal one and the one with the dissection with the line. So that's why we always promote for a CT scan. So like I said, symptoms in children are rare. When a child, any child with chest pain, usually it's just growing pains, not anything bad. But if your child has Marfan syndrome, it's always important to be careful about that and have a low threshold for CT. The final thing I've said about symptoms in children is that palpitations are possibly slightly more common than we previously thought with Marfan syndrome. So that's also something to be aware of. This is like, I just heard the door downstairs. This is my husband, who's also a doctor, because my family is all doctors. And I met him in the lift in the hospital. And he had a very cool square stethoscope, and he does bone marrow transplants for multiple sclerosis, and I'm very proud of him. One of these is a Marfan mouse, which is an experimental model where we learn a lot about Marfan syndrome, and we can also do trials on medicines. And there's my son with a dinosaur. So we have different medicines for Marfan syndrome that we use in children. And I've got like the pictures of the commonest ones that we use there. They've all got different pros and cons, but they're really quite widely used now. And there's different studies that have been done. And this is like one of the most famous journals in the world, the New England Journal of Medicine. And this paper was written by one of my friends, and also Dr. Charles' friend. We're together on a conference there, and that's looking at different medicines in children with Marfan syndrome to see which is the best. This is my dad, who's a cardiologist, and he's the reason that I'm here. He introduced me to a patient with Marfan syndrome when I must have been about 6 years old. He always used to take me to work with him. And he introduced me to a lovely lady who had Marfan syndrome. And she was saying to him, oh, you know, I need you to look after me forever, and I don't want you ever to retire. And he said to her, don't worry, when I retire, this lady will look after you. And I kind of remembered all of that. And he's always inspired me, and he has an OBE, and that's why I'm here today. I very much like teaching. This is one of my teaching sessions, and these are my kids, and here's the drugs. So, oh, sorry. So have I run out of time, Victoria?
We usually it's 20 minutes for a presentation, but this is fascinating. I don't
know. I've really got no idea, because I feel like I've been talking for 5 minutes, but I'm a real chatterbox.
No, I think carry on.
Are you sure?
Slides to go, yes.
Okay, so these are the common medicines that are used, and if you've got adults in the family, they may have been taking medicines like this. So irbesartan is a newer angiotensin receptor blocker, and another form of that same drug is losartan. And people are often not often, always concerned about giving medication to children. But what I'd say is that they're very well tolerated, these medications in children. Atenolol is a beta blocker, and we have that in a liquid form, which is like very important for children because children at the beginning can't swallow tablets. If you have a child who is a little bit older and you want them to learn how to swallow tablets, on Instagram, I've got a video of myself teaching children how to swallow tablets. On Instagram, I'm on Dr. Nitha, Nitha, Naqvi, Naqvi, and Victoria can give you that Instagram link. Actually, children as young as 2 can learn to swallow tablets. It's amazing. Not that I'm saying that you need to teach your child at that age, but actually very young children can learn to swallow tablets. I just wanted to put up ADHD because ADHD is like now increasingly common in the whole, we're realizing in the whole population, it's 5 to 10% of the population. But one thing we do feel is it's slightly more common in Marfan syndrome. And what I'd say is that in my personal opinion, I do take care, but I would never stop anybody having ADHD medication. If overall is thought to be in the benefit for the child, I would definitely support that because we want our children to reach their full potential. We used to say that now if you're born with Marfan syndrome, with the usual type of Marfan syndrome, and I don't mean neonatal Marfan syndrome, which is a slightly different condition, the lifespan we used to say is in the 70s, but I think it's probably even better now. Now we understand so much more. So one of the things we used to do was we used to really limit people's exercise. We were so worried that exercise was dangerous for people with Marfan syndrome. We didn't allow them to do it. And obviously, if you don't exercise, we know that to anybody without Marfan syndrome, we would say exercise is very important for longevity and living a long life. And now we realize that actually exercise is very important for everybody. So we're much more liberal than we used to be. The Marfan Trust, years ago, we had a leaflet about all things not allowed. And now we've very much changed and we've realized not all types of exercise, but many types of exercise are good. This is myself at London Aorta, which is a meeting where all of us as aortic experts meet. And this gentleman, some of you may know, Tal Goldsworthy, is there wearing a T-shirt with a picture of an extent, which is something that we do use on surgery in children. I'm just putting this in here because some of you may have heard of this operation. There's lots of different, and in fact, these figures are totally out of date because now we've done this type of surgery on many more children. But if you hear about the pairs operation, sometimes people call it a sock, where instead of what we used to do, which was to cut out the abnormal aorta if it became too big, now instead of doing that, we put a wrap on it, which is, it's like a bit, we call it a sock, but it isn't really a sock. It's an individually made 3D printed special material that we put around the patient's own aorta so that it can't grow anymore. I'm now reaching the end. This is our wonderful Dr. Child, who is like certainly my heroine and is somebody who's done so much work with Marfan syndrome and leads the Marfan Trust with our fantastic Victoria. That's a patient day for children that we had at Chelsea Football Club. This is my daughter who I'm working on in the same way my dad was working on, to be in the future looking after people with Marfan syndrome. Just to mention that now, sometimes even in fetal life, we can measure the aorta and notice that there may be a problem. So this is actually, these are scans of the baby's heart in the womb, and people looking at it then. But if you have a family history of Marfan syndrome, it's just on a scan of the baby in the womb, it's too difficult to say on that whether the person has Marfan syndrome or not. But obviously genetic testing could be done. Neonatal Marfan syndrome is a different condition. And just because your child is diagnosed with Marfan syndrome when they're a baby or in the first few years of life, that doesn't mean they have neonatal Marfan syndrome. It's actually really a quite different condition, with different features. There's often like confusion about the names, and they're treated in different ways, but there are experts who look after all of them. I just wanted to say that in my hospital, we have a pathway to make sure we can treat children as quickly as adults if they have an aortic dissection, because you probably have seen, like with things on the television, about if you have a stroke, how you've got to get to hospital really quick, and there's a whole plan of what to do. And similarly, if you heart attack, there's a whole plan of what to do. There is actually a whole plan for aortic dissection for adults of what to do as well, and we have a plan for children if it were to happen. So those are the main things I wanted to talk about. I was talking about how CT scan is important. I've talked a little bit about drugs, and I can go into more detail if anybody wants to ask. But I want to say it's very important to be very optimistic for the future. Looking after people with children with Marfan syndrome, it's like very rewarding for me, and it's just like wonderful to see them all doing so well, and having going to university and having plans for their careers and their futures. We know that there's about 15,000 people in the UK walking around with Marfan syndrome who don't know they have it. So if you feel anybody may have some features of it, do ask them to go for a checkup. Because or get them to phone Victoria, get them to phone the Marfan Trust. That's another thing. So thank you for listening to me for all of that. This is me on the big screen at Piccadilly Circus. And then here again is the wonderful heart. We're ending with the amazing heart, which is what we've been talking about. So I'm going to stop sharing there. And if I can, yeah. And then I don't know if anybody had any questions.
Just to say thank you very much.
What the time is.
Thank you so much, Nitha. I said you were a tour de force, and that's what you are.
Well, thank you for listening, because it's very good of people on an evening to listen in.
I've collected some questions, and some you've perhaps integrated into your talk, but so the mother of a 3-year-old girl with Marfan syndrome, they're anticipating their annual cardiology appointment in a few weeks' time, with the expectation she's going to start losartan. And naturally, the mother's slightly apprehensive. The child has a slightly enlarged aorta. Is there anything they should be asking or should expect from this appointment? Are there side effects, short or long term, of? I think you've probably answered that.
Yeah, what I'd say is that, we do have experience with losartan. One of the things about losartan is, I have like one family who have like an amazing pharmacy that have a liquid form, but otherwise, I've never been able to find it anywhere else. So it's just in tablet form. But what you can do is you can actually quarter this tablet and then crush it and mix it in with various foods, so that then the child, even if they don't want to swallow a tablet, can have it. So that's a way of giving losartan to younger children, even though it's a tablet. The main side effect is that if it lowers the blood pressure too much, it can make the person dizzy. That said, you will always be started on a very low dose. So that and in children, often it's difficult to even keep an eye on the blood pressure, because they get so angry when you check the blood pressure that it's just so high that it's not really a real reflection of their blood pressure. But in my experience, it's extremely well tolerated, and it's being given to children all around the world, and All I usually say to families is if your child's not well and not drinking normally or eating normally, then just don't give the medicine at that time because it does lower the blood pressure. And if you're not drinking well and are a bit dehydrated, then that can make you more unwell. I also, in the guidance, it always says if you start a medicine like losartan or irbesartan, to check the kidney function with blood tests every year and after starting it. The reason that that's said is that usually people taking these medicines, because Marfan is not very common, usually these medicines are given to elderly people for various problems they may have with their heart. And elderly people's kidneys are not functioning as well as a child's kidneys, which is pristine. So when we did our big AIM study where we tested irbesartan, which is like losartan, we didn't have a single child who had a problem with the blood with when we checked the kidney function. So in theory, it's a risk that it can affect kidney function, but in practice, I have never ever seen it affecting kidney function. And even in the study, when we did so many blood tests, we didn't see any problem. But if you want to be cautious, then the bloods can be checked. Some children are really needle phobic, and that's the worst thing in the world for them. And then that's a discussion with your doctor as to whether you want to check it or not. So that's losartan.
Perfect, thank you. A parent has just actually emailed me to ask, they're interested to know about implications for surgery when you have a connective tissue disorder, such as Marfan's, but also other issues, such as a bicuspid aortic valve and dilated aorta.
Okay, so are you saying that the person has Marfan and a bicuspid valve and a dilated aorta?
That's my assumption. I have no, that's it.
Or is it that the person has a dilated, because with bicuspid aortic valve we do get dilated aortas for sure. Usually if you have bicuspid aortic valve and your aorta dilates, it doesn't tend to dilate to the same extent as Marfan syndrome. If you've got bicuspid aortic valve and the aorta is still continuing to dilate, it's always worth thinking, could there be an underlying connective tissue disorder? Because bicuspid aortic valve is much more common. It's like a couple of % of the population compared to Marfan syndrome. So that's always worth bearing in mind. Regarding surgery, there's different operations. You can do the traditional operations, which I didn't have a slide of, but there's 3 different ones that can be done, where you would be removing the tissue and putting in different tissue, or putting in a tube and maybe repairing the valve. The one that I showed you, which is the wrap one, is the pairs, which is the one that at my institution we prefer, as long as the bicuspid aortic valve is not got issues itself. But even if it has issues itself, if it can be repaired, then you can still do the pairs at the same time. Some surgeons, though, prefer to do different types of operations. I mean, the main thing is you want a surgeon who knows what they're doing and is confident for a good outcome. That's the main thing. At my institution, we always go for pairs in somebody with a connective tissue disorder, or even if they just have, I mean, I haven't had anybody with isolated bicuspid aortic valve and an aorta so dilated that they needed an operation. But we do certainly operations on aortas in children with all different kinds of things from birth. So there's lots of experience because of that type of surgery. It's a bit hard for me to say anymore because I don't exactly know the anatomy that we're talking about.
No, and that's the extent of my knowledge.
Yeah, and one of the things it's worth always asking is, because if it's an institution that never does a certain operation, they're never going to do another operation because that's the one they're very good at. But you know, if you do your reading around and you would like to get a second opinion from an institution that does things in a different way. That is always everybody's right to ask for that. It may take a long time because, you know, our appointments are always delayed for everything, unfortunately, at the moment, but it is always everybody's right and option to do that.
Perfect, thank you. Donna's written to say, thank you, this has been extremely informative. At our last cardiology appointment, my 5-year-old son with Marfan had a Z score of 2.18 for the sinus of Valsalva and the aortic valve score of 1.76. The cardiologist elected not to start medication yet.
Yeah, I mean, everybody's going to make their decision in a different way. So, I myself, now, most usually, if a child has Marfan syndrome and it's genetically proven, I would be pro starting medication even if the aorta is normal, leave alone if the Z score is plus 2.1, because my aim is to get the lifespan not to 70, but to the same as the normal population. So, but in America, you know, I showed you that picture of me with that gentleman. The American guidelines are suggesting to start at +2. Europeans, we used to do that, and now in Europe, most of us who are specific Marfan experts rather than pediatric cardiologists seeing a couple of Marfan patients, a few Marfan patients, seeing only Marfan patients, not only, seeing many, many Marfan patients. We in Europe and most in the UK have now moved to thinking about being more proactive. But that's also with discussion with families, because families may not want to do. And certainly, like if a parent has Marfan syndrome and they've never had any problems with the aorta, they might have had problems with their eye or their back, but never had any problems with the aorta. They might say, well, we don't want to because we've never had that problem. And there's certainly something to be said for that. So it's like a team approach between the doctor and the parent, and also thinking about the risks in the family. If the child was the first person in the family to have it, then certainly you'd be having an even lower threshold for starting. If there's somebody in the family who's had an aortic dissection, again, you'd have a lower threshold for thinking of starting.
Although, can there be disparities in families? I mean, within families?
Yes, definitely.
So
Definitely.
the parent have Marfan syndrome, pass it to the child, and the
Yes,
parent.
and sometimes parents assume the child will behave in exactly the same way, and they behave in a completely different way. In the same way that when we have children, you know, parent can be slim, child can be chubby, or opposite, you know, parent can have normal eyesight, child can need spectacles, you know, it doesn't follow completely, of course.
And if the child's sometimes a boy, it could express itself more severely with the aorta, perhaps.
What I was saying then is it's when they are the first person in the family to have it. But even then, it doesn't hold for sure. But one of my colleagues from Oxford, he always says, like, why would you wait until you have toothache to go to the dentist? Wouldn't you look after your teeth and brush them and go to the dentist regularly so you don't get toothache? And he's kind of saying it in the same way, why wait until the heart is abnormal before you start looking after it very carefully? It's different ways of thinking.
Chris is
Unfortunately, I just want to say, unfortunately, what people really would like to know is what is the best thing to do and what is the evidence. And we don't have that evidence because it's quite difficult to do trials on children. There's a few trials that I did show you, but it really is quite difficult because trials involve a lot of blood tests, a lot of assessments, and people don't want to put their child in a trial usually, especially if there's a risk that they may get a fake medicine, which is the placebo. So that's one of the difficulties we do have, and that's in everything in children, actually, not just Marfan syndrome, for all drugs.
exactly. And Donna's just because it was her question. She said, "I have Marfan, as does my 7-year-old daughter. Lens dislocation has been the biggest issue for me.
Mm.
Both kids are the same. We have a strong family history of Marfan. Genuinely can't thank you enough for your time.
Thank
Chris
you.
asked, could you please explain what factors would lead you to consider a pairs procedure?
So if a person's aorta was this, so I'm talking about children. So if the aorta looks like, it's usually the bit that enlarges is the sinus. So you know when I showed you the onion picture, it's the bit in the middle of the widest part of the onion, that's the sinus. So that's the measurement we're really most interested in. It's always the biggest measurement. So once it starts approaching 4 centimeters, so that's an actual value, 4 centimeters, then we would look at more advanced imaging than an echo, which would be an MRI and or a CT. And if on the CT it's looking like it's 4 centimeters, then we would start considering for a pairs, because what we would like to do, the aim with the pairs, is to do it when the aorta is more normal. You can certainly do a pairs a bigger size. So we started off doing surgery when the aorta was 5 centimeters, because the risk of dissection becomes more at 5 centimeters. But gradually over time, that number has been coming down. If you have an aorta that's bigger than 4, it's not like you've missed the boat for any surgery. It's just what we're saying is to have the shape to be as normal as possible, so that the flow dynamics remain as normal as possible, to try and give you the longest lasting operation and the longest normal physiology. We actually have special MRIs where we can see the flow of the blood, and we can see that if the aorta is more normal shape, the flow is much more normal, which is better for you and better for the rest of your aorta. Because even if you treat say you did a pairs and you treat or another type of surgery, the beginning of the aorta, that doesn't mean you're not going to have problems later on with other parts of the aorta. So in my practice, it would be if somebody is reaching 4 centimeters. So usually we're trying with these drugs to try and prevent that happening. That's the whole point of the drugs. But in some people, despite that, it still keeps enlarging, but we do feel the drugs are at least slowing it down, so that surgery is needed later, and rather than in a little person. But the pairs operation has actually been done for different conditions, not Marfan syndrome, but for other conditions where the aorta is enlarged on children as young as 2 years of age. So there isn't a kind of lower limit really. But my normal practice with Marfan syndrome would be when it's reaching around 4 centimeters.
Thank you. And Alex has just commented, emphasizing the disparity between men and women, males versus females in my family. My uncle died at 32. I had aortic root replacement at 28. My mum was fine until she was 64. My nan died of a dissection at 70. So in his family, there's a big discrepancy. Holly's just asked, my daughter's Z score is 3.4 on the A3 and 2.54 on the A2. What score
I'm
tends
sorry, I don't know what an A3 and an A2 is. I'm sorry. It's probably every unit measuring things in a different way. I don't know what an A3 and an A2 is. Another problem is there's loads of different Z scores. So that's not very helpful. There's a Lopez Z score, a Detroit Z score, a Gautier Z score. There's lots of different ones. And some of them, you would measure the aorta and the Z score will be +4. But if you do it with a different computer program, it's +3, and a different one is +2.8. So that's another problem. So each cardiologist will have chosen the Z score they're going for, and it's more the as you look over time, as long you've got to keep making sure you use the same one and that the measurements are made in the echo in the same way, because some can be measured when the heart is contracting and some when the heart is relaxing, and obviously that's going to change the size of the aorta as well. So it's quite complicated the way we measure it. So I think you said something about some Z scores, but I'm sorry, I don't know what the A2 and A3. It might be the valves, the sinus, and the sinus-tubular junction, maybe, but I'm not sure. Sorry.
No, I've just asked Holly just to clarify, I think. Sinotubular A3.
Okay, so you said the sinotube split, so you get me some kind of A2 and A3. What did you say?
So 3.4 on the A3, which is the sinotubular, and 2.54 on the A2, which is the Valsalva.
The sinus, yeah.
Yes.
But I'm sorry, I'm not sure what's the question. Those are the measurements.
So Holly's asking, what score do you tend to start to worry as a cardiologist?
I'm not sure what worry means. What I would say, are you saying when would start drug treatment?
She's anticipating losartan in a few weeks' time because her 3-year-old daughter's seeing their cardiologist, and she expects him to prescribe losartan. And yes, she's asking the question of the Z score because her daughter has a slightly enlarged aorta.
Yeah, so as I said, if I have somebody with Marfan syndrome, regardless, as soon as I see them, I put them on medication anyway, regardless of the Z score, because I'm trying to keep the Z score normal. Everybody's going to do things differently. And like I said, I had my disclaimer because I haven't seen your child, haven't seen the echo. In my practice, what I do, I'm always thinking of starting medication on anybody with Marfan, period. In young children, I normally start with a beta blocker because it's a liquid. It's much easier to give young children a liquid. And then I then also would be, if it continues to enlarge, I would then be increasing the dose of the beta blocker. And then if it continues to enlarge further, then I would be thinking of something like losartan to add on because the losartan is the tablet. But everybody's working slightly differently in how they do that. But that's always been my practice. Also because beta blockers we give even to newborn babies, so we've got a lot of experience of giving them in very young children.
Brilliant.
That's how I normally do it. But like I said, there isn't a guideline saying you must start with this medicine and you must start at this time. We don't have that.
No. Catherine's just written to say thank you for an informative session. Her 40-year-old son was diagnosed last year, saw you in May, and will see you again in May of this year.
Great.
So thank you.
Great.
Somebody's asked actually a question of genetics. His 14-year-old son will have his first consultation for genetic counselling in June. He was hospitalised in December with a spontaneous pneumothorax. He has possible markers of Marfan syndrome, arm span, flat feet. The ultrasound of his heart indicated everything looked good, but he remains worried that something could develop because he's only 14.
And that's a situation we very, very commonly see because, like we said, with Marfan syndrome, you can have your aorta dilating when you're very young or not dilating until you're 70. And that makes things very hard. So that's why if there's a genetic diagnosis, that's really helpful because if it's positive, then you know that you should be seen every so often for heart screening. Sometimes it's equivocal and it's not clear. And of course, there are causes of Marfan syndrome that are genetic that we haven't discovered yet, because even if you look like 10 years back, we didn't have the number of genes we've discovered now. And every 5 years, we change our knowledge. So we often, if we do genetic testing, we often ask if we can store the blood so that if we get more tests in the future, we don't have to prick your poor child again. We can just use the same blood sample. So, but there are a lot more people who have a pneumothorax and have flat feet who don't have a connective tissue disorder and don't have Marfan syndrome than do. So there's a number of features, and when you see a geneticist, they look at the number of features to decide whether it's the right thing to do genetic testing. It's a little bit frustrating that because often families feel very reassured if you have a genetic test and it's negative. But it's a bit of rationing to a certain extent by the NHS because these genetic tests tend to often cost about £1,000. So that's part of the reason they don't do it on everyone. If they're kind of in the unsure group, which I see a lot of, what is often a compromise is to see the child every number of years while they're growing. And we normally say children are growing until they're 21. So they don't have to come like every 6 months for an echo, but if there's kind of like a concern, but the geneticist is not sure, then it may be that they just say maybe go every like 3 years for an echo or every 2 years, something like that, to make sure everything's okay. So there's different things that can happen in the genetic appointment, but it's very useful to go and see a geneticist. And the thing to remember when you go and see a geneticist is you don't have to agree to the test. The reason you're going to the geneticist is so that you have the knowledge to make the decision about what you want to do with the testing. But I always recommend people go and see geneticists because they will give you their thoughts on how likely it is. One of the issues if we do testing is we often found this problem where we find what we call a VUS, a variant of unknown significance, which is really annoying in that we've found that the genes are not quite normal, but it's not actually Marfan syndrome. We don't really know what it means. And then you're lumbered with that. And then you're kind of, got this thing, you don't even know what it means. So we do always warn people about that being a possibility as well.
Yeah, because sometimes the label of a syndrome can be comforting. Like one of our patients, he says he has Marfan syndrome. He was actually diagnosed with a VUS, but his clinical features are of Marfan syndrome, and he's had
and the main thing is you want to keep yourself safe. And the main, for me, obviously, the main risk is the heart, but obviously, the eyes are important as well. And then if there isn't a genetic diagnosis, but there's a lot of features of Marfan syndrome, I have a significant number of patients in that group. And what we do is every so often we do the echo as they're growing. And that way, if it remains normal, great. And if it doesn't, we'll find out soon before there's a clinically important problem.
Exactly. I'm just going to scan the gallery for any further questions. I think I've exhausted my collection of questions. One lady did ask.
That was a lot more. Normally we have like one, which I always know is a fake one that Victoria's made up herself.
One lady, she wonders whether her child has neonatal Marfan syndrome. Her child was diagnosed at the age of 2.5, just clinically with an enlarged aorta and subluxed lenses. And the mother wonders whether it would be written on the genetic report. She herself has mosaic Marfan syndrome.
So I think it's very unlikely because neonatal Marfan syndrome, as we know it, and some people call it different names, is the most severe form of Marfan syndrome, and it never runs in families. It's always sporadic. It's a new case.
Yes.
So I think that seems very unlikely. And untreated, unfortunately, untreated neonatal Marfan syndrome has a very poor survival rate to 2 years. So I think it's very unlikely that your child would have what, if you look up neonatal Marfan syndrome with all the serious problems, I think that seems unlikely, but the right person to go and see would be a geneticist because neonatal Marfan syndrome, the gene mutation is different to the standard Marfan syndrome. So it's not a complex thing to find out.
No, exons 28 and 32.
Exactly. So it's quite different.
And I think Jasvinder, it says Zoom user, I think that's Jasvinder, said, thank you ever so much for a brilliant, informative evening. I'm so
lovely to see you all.
Progress. Although
nice to see friends.
He doesn't have her son doesn't have Marfan but Loeys-Dietz, and he was under your care.
Of course. I remember all my patients and I care very much for all of them. I'm fond of all of them. And I know that I am very, very lucky to have my job. It's a real privilege.
Well, we're really lucky to have you and potentially Sophia when she graduates.
Let's see what happens there.
We hope she's volunteered for us. So thank you so much, Nitha.
Okay, well, thank you, all of you, for coming this evening.
Thank you very much, everyone.
Best of luck with everything.
Thank you.
Bye-bye.
Bye.
Bye-bye.